Hi, everyone, and welcome back to the Clinics in Sports Medicine podcast series. I'm Megan Ashdown, Clinics Editor here at Elsevier. Clinics in Sports Medicine is a quarterly publication consisting of review articles focused on a central topic. Today, we will be discussing the October 2024 issue dedicated to shoulder instability, guest edited by Dr. John Dickens and Dr. Brian Lau. Here now is the consulting editor of the series, Dr. Gwathmeh, to lead the discussion. Hello and welcome back to the second episode of the Clinics in Sports Medicine podcast. I'm Megan Ashdown, Clinics Editor at Elsevier. Joining us today is Dr. John Dickens and Dr. Brian Lau, guest editors of Volume 43, Issue 2 of Shoulder Instability. With us here today is the consulting editor of the series as well. To interview them, Dr. Gwathmeh.
So thank you, Megan. My name is Dr. Winston Gwathmeh from the University of Virginia, and I have two of my good friends from down the road at Duke talking about one of my favorite topics, the topic I think germane to all people and providers who take care of any athletes, any sports teams, that is shoulder instability. So we're going to get right to it. So Brian Lau and John Dickens from Duke, thank you for joining us. I'm going to get right into the questions, okay? So John, tell me about how you guys put together this issue and kind of how you chose your chapters and authors.
Yeah, well, Winston, first of all, I think thank you for having us on, and it's a tremendous privilege to be on the podcast. I think I've always found that these are a tremendous augment to the text, and has been a great way to communicate with people. So first, thank you for that, as well as the invitation to contribute to the Clinics in Sports Medicine series. I know through the years, whenever the shoulder instability topic comes out, it's just such a great summary of all the facets that are relevant to the sports medicine surgeon for shoulder instability. And so we really wanted to kind of bring that back to fruition this time around, and sought to really kind of hit all the hot topics right now, what's relevant to all the different sports, anterior, posterior, some of the more nuanced topics, certainly bone loss and rehabilitation, surgical indications and treatment were all kind of the things that we wanted to hit. And then once we had our topics, we went out to the folks that were certainly the leaders in the field, and, you know, without reservation, they all said yes. And so I think we got a really great lineup and a great Clinics in Sports Medicine edition.
Yeah, I'd agree. I think that I look forward to these types of issues too. It's nice to have everything in one place, just to have a one-stop shop for all that is shoulder instability. I think there's been so many developments as well, and so to have the updates is really helpful too. So Brian, talk about the shoulder. Why is stability so important? What makes it so unique as far as being a joint for instability? I was reading that functional anatomy and biomechanics chapter by Dr. Johnson. Go ahead and tell me why the shoulder is so unique.
Yeah, well, again, I echo what John said. Thanks again for having us on this podcast. We really enjoyed the opportunity to put together this series, and a great opportunity here to talk about it. So for the shoulder, I think, you know, why we all love shoulder, it's such a unique joint. It allows you to do so many different things with like 6 degrees of freedom. It allows you to throw a baseball like over 100 miles per hour, yet allow you to reach around your back and everything. And so I think the biggest thing about that is all that range of motion and degrees of freedom, there's not a whole lot of bony kind of stability. So there's a lot of things that require soft tissue-wise to provide a stability. So you have the labrum and your static and your capsule, as well as the dynamic factors, including the muscles, that the rotator cuff muscles. And so given that amount of really the shallow, bony kind of interface and all the soft tissue requirements, it makes it really unique because you want to be able to provide the flexibility to do all the different unique things that a shoulder allows you to do, at the same time provide some stability. So it's that kind of that balance, which makes it unique, different than some other joints where it's really constrained by the bones and less degrees of freedom. And so what makes it so fun and unique to all the things that we can do with it also makes it prone and vulnerable to injury and instability because of that.
I couldn't agree more. I think it's a miracle of the joint. just all the things allows the opportunity to do. It wouldn't be able to be possible without that arc of motion, without the just the ability to do so much. And so I think I was going back to you, John. You talked, I think, when you're talking your first question about different types of shoulder instability. How do you differentiate between anterior and posterior instability? Sort of what's the different strategies to evaluating and treating them?
Yeah, no, that's a great question. I think, first off, in the literature, I think now probably more than even 10 years ago, we've seen increasing amounts of recognition of posterior instability. And this is part and due to our ability to recognize them both diagnostically, our ability to treat them, and then our ability to diagnose them. And one of the principal things, obviously, the mechanism of injury certainly gives us a clue, the type of sport played. So our football linemen who are blocking with their arms forward flexed, those are going to be obviously the more posterior instability. And then our defensive backs that are making arm tackles with an arm in an abducted external rotated position sort of are setups for anterior instability. But, aside from the mechanism of injury, I think some important differences are how they present. And I think it's emphasized in our chapter here, but really what it comes down to is your history and physical examination. Importantly, instability shouldn't be painful, especially anterior instability. And so if they have restored their range of motion but complain of instability, particularly in the abducted external rotated position that suggests anterior instability, posterior labral tears, posterior instability can be more painful. And so that's a little subtle kind of finding. They might complain of weakness, particularly with bench press or overhead press, and maybe more pain symptoms. And then you can get some other clues with other injuries as well. But those are really helpful cues to start out with. And then obviously the exam finding, with the apprehension being the most sensitive, especially in my hands with picking up anterior instability, and then our posterior load shift, our KIM, and our jerk test really helping to differentiate that posterior instability and labral tears.
Great. So Brian, so you have an in-season athlete who has anterior instability. What's your decision-making criteria as far as if he can play, if you need to have surgery, what type of imaging do you like? Just let's talk anterior instability for a little bit. In-season athlete, one of your football players down there at Duke.
Sure. So again, it depends a little bit on anterior. I think that's probably the easier one to go through. So, anterior, if they have an acute dislocation on the practice sidelines on field, generally you're going to want to get x-rays. And that's kind of the first line. If any kind of fractures, that obviously changes things. Obviously, there's associated fractures like greater tuberosity fractures, and that will change management. But generally speaking, I think most people are trying to get MRIs even for the first time now, as we're getting a better understanding that bone loss can even occur in that really, even with just one dislocation. And trying to get a sense that obviously if there's a bony fragment to that, that's going to change kind of the in-season management and that discussion. But if you're talking about just kind of standard anterior labral tear in an in-season football athlete, it really depends on their position. So if they're in a position where they got to really reach up, maybe like a wide receiver, really reaching back and moving that arm in vulnerable positions, then you may be more inclined to try to blow them out or make sure that they're more protected. If they are, obviously they're like a quarterback and throwing, again, you might be a little more careful returning them back. If you're a lineman where they're, or a linebacker where their arms are more down by their sides and tackling and form tackles, it may be a little bit more protected. So again, it's really a discussion about their position, what their goals are. But before you try to treat them conservatively, they got to have full range of motion, full strength, be able to protect themselves. So it's not typically something you're going to get back from the very same game. It's going to be, at least a week or two to really see if they're able to protect themselves. So advanced imaging typically for all of them early on to get that sense. And then other sports, again, I would still recommend getting imaging early on as we're getting a better understanding of the damage and the things that can happen, and even if a primary anterior dislocation. For posterior, I think it's a little bit different. Those patients, as John just highlighted, present a little bit differently, tend to be a little more chronic, tend to be more pain, less instability, and more disability. So that's pain or weakness. And those patients, typically like a lot of linemen or whatever, they have their arms up a lot and kind of doing that posterior force. Those patients, you may try to treat them more conservatively rather than someone who has an acute dislocation. So a lot of it is kind of what direction is the instability, what position they play, and then really a shared decision making early on. And we have to use a lot of bracing. Like Sully bracing can be helpful if you're trying to get people back in that same season, or even after surgery. Some patients like to have that as an extra sense of confidence in returning.
Yeah, I'm sure you guys are like we up here UVA. I mean, if we can get a player for the season, that's great, as long as they don't have recurrent instability or events during the season. But I feel like at the end of each season, we sort of line up our players, and we have all their shoulders, and we determine kind of who needs to be fixed. Is that kind of how you guys see it down there at Duke as well?
Yeah, and I think, I mean, as you know, it's even if they're not complaining of instability events, they're having recurrent subluxations to some degree, and I think probably 2/3 of athletes in season are having some sort of recurrence, usually between 2 and 3 episodes of recurrence in the season, and they may or may not report it. I think the ones that get concerning obviously is the recurrent dislocations more so than subluxations, with kind of worry about increasing bone loss. But absolutely, I agree. I think we're fortunate to be able to good hands on with these athletes, so we can follow them and really be able to judge their rehab. But at the end of the season, we do see a lot of treatment. And I think what Winston, tell me if it's different for you, but if you're treating these guys after a season, their shoulders look a little bit more kind of like they've had a couple instability events versus that kind of nice high school athlete that has 1 or 2. I mean, I think you guys are playing high level football over there, so I would imagine you guys are having some shoulder injuries, but I don't know. Tell me if I'm wrong.
You're exactly right. The unfortunate thing or fortunate thing at UVA, the off season's a lot longer because our season ends a lot sooner. For not playing in January, that's meant to be against. But I would agree with you. Well, you have that event in October. Let's talk football. An event in October, November, whatever it might be, and they play 3 or 4 more games. You have an MRI from their event, and then you go to fix them after the season. Then you realize that MRI was, that MRI. There might have been some additional injuries since that MRI occurred. I mean, I don't know about you all. Do you repeat imaging at the end of the season, or you just use what you have, or how does it work for you down at Duke?
I just say, we've been fortunate, and maybe have not initially here, I think, been as getting MRIs as early on, certainly getting x-rays, as the landscape of college sports and football is changing a little bit, and some of the dynamics. I think we're seeing some of the MRIs happen a little bit early, like immediately after an instability event. But to your point, I think if there's concerning changes, if the exam changes, if they have multiple recurrent instabilities, I think it's worthwhile to get an updated MRI, particularly because that could change decision making. But I'm not sure how you're doing it, or Brian, what your opinion is here.
Yeah, again, it depends if they have multiple episodes or something's changed since that initial injury. A lot of times, unless there's a concern for gross bony abnormalities, we're still, at least here at Duke, we're still generally trying to do a soft tissue repair initially. So I agree. A lot of times you get in there like, wow, this is like 270 type tear rather than just simple quarter of the cervical nerve tear. So it definitely ends up being more severe at the end of the season, but not always necessarily repeating an MRI unless something makes me prop that.
So Brian, you use the term soft tissue injury. What's your approach, surgical approach, to the soft tissue Bankart tear in a collegiate athlete?
Yeah. So I think that a lot of work that John has done here and has been highlighted in some of our chapters is that the degree of bone loss, lower and lower degrees, and can make a big difference, and maybe necessary for repeat instability, but for patient-reported outcomes, how well they feel, how confident they feel in their shoulder. We've been fortunate here at Duke that we've developed some advanced imaging where we can actually have a 3D MRI where we get all that bony kind of measurements along with the soft tissue measurements. And, that's becoming more and more popular. I think there's several studies out there kind of presenting the similar data on that. But, generally speaking, if we can, we're going to try to do a soft tissue repair. And if that is the case, I'm typically doing a 4-anchor repair. So I'm also including one in the 7 o'clock position. So come in really trying to bring up the hammock of the inferior capsule. And so trying to do that in a standard repair. Obviously, as we just highlighted, sometimes these tears, especially at the end of the season, can be a lot broader and like all the way around. And then obviously just being a little more aggressive, a couple more extra anchors to stabilize it. But what's your approach of what kind of soft tissue? Are you leaning more soft tissue? Or are you going straight to a ladder J for some of your athletes there?
Well, I think if it's a soft tissue injury, I lean toward a soft tissue procedure. But I do think a ladder J kind of brings a second element in. Without bone loss, I'm always concerned about changing the anatomy too much. Obviously, you want to try to mitigate the risk for recurrence. At the same time, don't want to necessarily alter the entire anatomy of the joint if you can get a good soft tissue repair. Now, that being said, I was actually looking very closely at your chapter 6, your open Bankart repair. I came from the land of Carter Row and Bert Zarin's up there when I did my fellowship up at MGH, and the open Bankart was just sort of a lost art, we feel like. And Bob Arciero has a nice paper or nice article here. John, maybe tell us about open Bankart. Do you ever see that as part of the armamentarium for high-level athletes?
Absolutely. I think it's a great procedure. I worry about in a football player, muscular patient with a lot of eccentric, heavy loads that are going to be pulling on that conjoint tendon over and over again. So outside of just graft resorption, just fixation problems or osteolysis, but fracture or hardware failure in these athletes. So in these folks that are in the tweener stage, I like to try to stick with this, and we've been fortunate to have a good experience here of the open Bankart procedure. There's obviously, I agree with you, Winston, a little bit of a lost art, but and truthfully, it's probably a technically harder surgery than a ladder J, certainly than an arthroscopic procedure. But I think it's worth knowing, and certainly why we wanted to have someone like Bob Arciero give us his pearls, because he's been doing it for years and been really successful with it. So excited to see that in this edition.
Yeah, I think that one of my favorite things about putting together a chapter list is trying to understand what the reader needs to know as far as what is germane to the treatment of their patients. And I do think that just by maintaining the open Bankart repair as an option and writing about it and showing the technique, people will continue to use it. And I've used it, and I think it's a great operation. It really is one of those things that once you're done, you're like, this shoulder is stable. You feel very confident. And although I think our arthroscopic techniques have become very, very good, don't get me wrong, there's still something to be said about coming at it from the front, being able to see those different layers and actually being able to put those deep stitches in and reef up that anterior capsule and anterior labrum. So yeah, but John, Brian, I think you mentioned bone loss and kind of your criteria for bone loss. Like, what's your threshold? When do you start worrying for one of your football players about bone loss? Like, do you have a way to approach that?
Yeah. So, again, we're fortunate here that we have the 3D MRI where we can do bone measurements off of MRI. So we're not getting 2 studies, but I think still most people are getting a CT scan. So if there's any concern in terms of recurrent instability, or even seeing some bone injury on just our x-rays in terms of Hill-Sachs lesions and stuff, getting that extra CT scan is really important to get that extra measurement. And I'm still kind of using the 3D reconstructions. And there is some more recent data that was highlighted as well that potentially even 2D MRIs, is the sensitivity of it is good enough now. I think most people are still kind of leaning toward a 3D CT scan for those measurements. The measurement set, historically 2025, in terms of bone loss is probably a little bit too high, as is highlighted by many studies now looking at 17.5 or 13.5. But for me, it's somewhere between 13 and 15% there where I'm starting to think that maybe I should be doing something else, whether that's a remplissage, whether that's an open Bankart. And, I'm going to hand this over to John because he's leading a study here right now with us called the Oasis trial, kind of trying to answer that question, that tweener kind of area. So high ones, more bony stuff, but that tweener, I'll kind of hand off to John to kind of highlight that study that he's leading.
Yeah, thanks, Brian. We were fortunate a little while ago to get a grant awarded in partnership with our colleagues up at Pitt. Two aims, really. One is a surgical aim. So in a subcritical bone loss patient population, looking at the 3 different treatment options. So an arthroscopic Bankart and rim plissage, assuming they have a Hill Sachs, an open Bankart, and then a Latarjet in that cohort. And then the second aim of that study is kind of the rehab component of things. So, which of these surgeries can we advance? Which of these are the patients, are the patients feeling like they can advance faster through some objective therapy protocols and testing, where we can say, okay, our return to play criteria and return to sport is optimized with each of these procedures. So that's the Oasis trial. It's a multi-center study. There's now, I think we're at 12 sites across the U.S. and adding potentially a couple internationally. So exciting stuff. Really early on in the study, though.
I think it's outstanding to be able to research that. I think all of us have our certain approaches to this, but developing these algorithms that are, provide the most effective and safe treatment for our patient, the least chance of occurrence, we're trying to do.
Taking a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
Taking care of college athletes, you kind of realize you only get one chance, really. Once you lose one season, if you have a failure, you can watch a athlete's career, go by pretty quickly without having the opportunity to participate if they don't get it right the first time. So I think talking more about the bone loss, let's talk about the main treatments for you. You mentioned Latarjet. Obviously there's some nice articles here in your issue on bone augmentation solutions, those types of things. Can you kind of tell me about Latarjet, about using a distal tube allograft? Those are the types of bony procedures, John or Ryan, either one, and why you'd use one over the other.
Yeah, so I feel like at Duke we're getting a lot more comfortable with the DTAs, but I think there's definitely still a role for Latarjet. So in those contact athletes, particularly football, I think that, and in bone loss, being around 20% or less, I think Latarjet is still kind of what I would still go to outside of our Oasis trial. I think DTA is a very, very powerful tool. And like I said, we're getting much more comfortable with it, particularly if the higher bone loss, greater than 20-25%. I think the DTA is going to restore that bone a little bit better. And, older patients who may not be contact athletes, I think maintaining that capsule using the bone block is good. Another thing that I kind of also factor in a little bit too is the capsule. So if I feel like the capsule is really thin, maybe not providing much restraint, then I think sometimes that Latarjet can be helpful also because you get that sling effect. And that might be more of assist with that, whereas a bone block, you may get a little bit less of that use of that capsule tissue if it's pretty thin. And that's just kind of my approach to it, but interested to see what yours, Winston and John, how you guys are thinking about that between the two.
Yeah, Brian, I agree. I think the DTA, while certainly exciting, we're still working on even midterm outcomes, and we don't know yet with the DTA, and obviously, I think there's a lot of reasons why we think it'll work, but I haven't had it I haven't been doing it in our contact collegiate football players, and the Latarjet is sort of for that higher degree of bone loss, even in that higher degree of subcritical bone loss. So, in that 15 to 20% range, and just worry a little bit about that with, some of these athletes. Winston, you guys might have more guys going in the NFL than we do, but Jim Bradley and Matt Provencher were looked at a series in the combine and just really high complication rates with the Latarjet. It's a small series, but just kind of gives you a little bit of pause. So for those kind of subcriticals in the 10% range, that's where I like that open bank heart. But you still got to have that discussion about range of motion issues with that procedure as well, particularly if they're doing a lot of overhead lifting and or in a wide receiver type position where they need to get their arm over their head.
Yeah, say up here in Virginia, our Latarjet experience has actually been quite good from a standpoint of return to play. And honestly, some of, we're on the fence. Sometimes our athletic trainers prefer that we do the Latarjet. I think they find it to be a more, I'd say, reliable, reproducible recovery. I think I've seen enough soft tissue failures to think that, and they've seen fewer of the Latarjet failures. But I think when a Latarjet fails, is much more, I'd say, catastrophic problem as opposed to a soft tissue failure. But that being said, I still think we're trying to figure that out. We do not have the same experience at DTA up here as far as in our collegiate athletes. I'm not sure we've done very many football players with distant tibia allograft or any sort of free bone block. It's typically a Latarjet in our hands up here.
Yeah, I was going to say, I talked with Dr. Greg Sabetovich from Ohio State, who does all the shoulders for Ohio State, which is essentially a professional team. And they do Latarjets for any instability. They don't do any soft tissues. Driven a lot because they had one soft tissue that failed really badly, and they've done Latarjets and those wide receivers going to the NFL. And so just kind of the culture there between their trainers and their medical staff, it's Latarjets for any instability, anterior instability. So it's just kind of a unique perspective on that. I wasn't anticipating that after we were talking just a couple weeks ago. So it's interesting.
Yeah, it's funny to talk about culture because we have players with instability. And these are football, 18, 22-year-old kids who are asking for the bone procedure. They're saying, I want the bone procedure. They come in a clinic asking for it, I want what this guy had or whatever it might be, because I think they've seen their occurrences just anecdotally.
No question. And Winston, I think you brought up maybe, one of the early reasons why, and that's because they probably feel pretty good. Is that your experience, that you can rely on their rehab earlier, they can get going a little bit faster? And
yeah, I think that you're not trying to protect some, suture anchor from pulling out of an anterior capsule. You got screws inside of a piece of bone. And it just, I think from a athletic trainer standpoint, from just the psychology of it, I think there are muscular differences between the two. And I know our trainers certainly think the rehab is a little bit faster than Latarjets. So speaking about return to play, how do you know when someone's ready? Soft tissue, Brian, and maybe
Yeah, so it was a great chapter here, and there's a lot more work and attention kind of going into this, looking about when someone's safe to return to play. It's a great systematic review by Michael Ciccati, which is demonstrated really the only thing that people are using is time, 4 to 6 months, and I say, and then just at that point you're good to go. Great study out of Pitt, which was highlighted in this chapter, which shows that just having a return to play protocol and battery decrease the risk of re-injury. And so I think that kind of sprungboard a lot of interest into this, and we're doing some of that work here as well at Duke. And we kind of do this mostly for surgical patients. I'd say we haven't really done most of our non-operative. The non-operative, again, is looking at strength, comfort, and confidence in returning to play. But after, for our surgical patients, starting at 4 months, we're doing a battery of tests, which includes a whole series of things, as well as force plate stuff. The two tests that we're seeing that are, not requiring force plates that are really helpful is a posterior shoulder endurance test, which is basically having them patient laying prone and doing a series of elevations based on the percent of their body weight, looking at endurance, and then doing we call it the full name is closed kinetic chain upper extremity stability test, which is essentially modified push-ups from side to side and reaching certain thresholds. And we're finding that can really, do a great job of telling us whether the patient is ready or not. Just straight strength testing, which a lot of people do, is probably not adequate enough. And some of our early data is also showing that with the ASH test, which is on force plates, can show that the maximum force you can get there, but how fast you get there doesn't recover quite as at the time that we're thinking. So I tell patients a lot, it doesn't really matter how fast or how high you got to get there pretty fast, or else your shoulder's going to already have dislocated or subluxed. And so we're seeing that as kind of something that lags. And so I think this is definitely a big area of research, which is highlighted in this chapter. A lot of interest in terms of trying to understand better when patients are truly ready to return to play. It's still an open question out there. I still a lot of early data on this, but a real area of interest. And I think something that we're going to learn a lot more in the next couple of years.
I was going to say, I'm curious what your experience has been, and Brian, maybe you can comment, but, just as we were talking about the differences between anterior versus posterior, it seems like, in my experience, and I'm curious what you guys think, but the posteriors, while they feel well, their strength takes a little bit longer to come back. Their return to play is just a little bit behind the anteriors, at least for when you're comparing kind of arthroscopic soft tissue repairs. I'm curious what you guys think about that.
Yeah, I think you're talking about two different animals there, because also a lot of them, once you stabilize the anterior instability situation, the additional stability makes them feel better. I do think they lose that apprehension. They feel better faster. The posterior instability guys, they typically present with pain, and it continues to hurt for a while afterwards. And I do think it kind of limits their rehab to some degree. But that being said, I think it's a different treatment goals for anterior versus posterior, and that is that in the anterior setting, at least in my hands, I'm trying to tighten up the anterior capsule. Like what Brian mentioned, I'm trying to bring up that inferior hammock. I'm trying to really reduce the shoulder volume, whereas the posterior ones, I'm not doing that quite so much. I'm trying to basically repair the labrum back up against where it came from. So I think it's two different types of injury mechanism. It seems to me to be different. But I do agree that sometimes it does seem slower. The guys that you're fixing from the back, a lot of times a pretty extensive labral tear there in the back as well. It sometimes includes the biceps anchor, which I also think is a big type pre-deteriorator as well. But yeah, I don't have a great answer for that. And I think we've got a similar series of tests that Brian uses as far as trying to figure out when they return to play. And the timeline, like you said, 4 to 6 months is that kind of arbitrary time point. But I usually try to make them think it's going to be about 6 months, and they'll start getting antsy when their shoulder is feeling better and not quite ready from a strength standpoint. Joe, let me turn it back on you though.
Yep.
Latarjet, what do you know when they're ready, and what do you see as far as your criteria to return them to play?
Yeah, I think it's as we were talking about earlier. I think they are a little faster to get back, and to a certain extent, they feel so good. They want to go back sooner. The Latarjet, the nice thing about the Latarjet is you can hopefully reassure yourself with a follow-up CT scan, show good osseous healing. I like to do that kind of in that 3.5 to 4 month mark. And once we have that and they're feeling good, if their strength measurements and their performance, and Brian's been leading the way with the return to play testing, which we're able to leverage here. If they're meeting all of those metrics, that's generally someone that in that earlier time frame of that 4 to 6 months is returning to play. You talk to some of our European colleagues, and they're certainly letting them go back way earlier than we are, and so that gives me a little bit of comfort level when we start talking about sending these guys back. But I'm not comfortable letting them go back yet until 3 months. I just think that the downsides to a complication in a Latarjet patient is just higher if you get into a problem there with returning them early.
I'm glad you brought that up. As far as you do have a nice radiographic criteria with the Latarjet. You don't have other types of surgeries. If you have a CT scan with osseous union, you feel pretty darn good that patient probably is stable. They've healed. As long as range of motion and strength is returned, I don't see any reason why not. But man, I agree with you. 3 months, 4 months, that seems just. I think maybe I'm more nervous than the athlete is as far as your training play.
Yeah,
I got a question to follow up on that. A CT scan at 3 months, say it's partially healed, but they're feeling great. What are you going to do? That's what sometimes I'm like, man, I wish I didn't get this, because I'm feeling so great. But it's not showing that. I'm curious, are you getting CTs all the time? Because sometimes, I just said, I'm like, man, I wish I didn't get that, because I probably would have sent them back already, But
yeah, I think on our collegiate athletes, I think we do have to have a CT scan showing, I don't know what percentage of osteousine you need, if it's partially 75% or 80% or 90%, they feel good. I don't know. John, is there a threshold for you?
Yeah, I mean, I certainly like to see, and it depends a little bit on the timing. I think a lot happens between the 3-month and the 4-month scan. So trying to get it closer to that 4-month time also gives you a little bit of a wicket, keep that athlete kind of in the wings before they're back out hitting. But yeah, I think I like to see at least 66 to 75% healing in that window to know that we're on the right track. If it's less than that, then I'm getting concerned.
Yes. So I was going to ask Brian this. What trends have you been seeing in shoulder instability since you started practice or since you started training? What have you seen over the last 10 years, and where do you see it going?
I think the big thing that we're seeing, which I think was highlighted in a lot of these chapters, is a real understanding of the bone loss, right? Not just on the glenoid side, on the humeral side. Probably the last several years, a lot more emphasis on humeral side measurements and how do we calculate that on track, off track, dislocation, near track. There's so many different ways that we're looking at that now. And then also subsequently the treatments for that. So whether that's going to be, more remplissage emphasis now, is it more DTAs, with lower amount of bone loss? I think that's the biggest thing I've seen in the last, 5-7 years since I started into practice here. And then, and it's been making it really, really, really interesting and fun. Really, I feel like there's so many new things that are coming out, and we have such a greater understanding of, how all that's influenced. But curious how you guys are seeing it as well.
So, Brian, you just your traveling fellowship. I went to Japan, and I had the pleasure of meeting Dr. Itoi. Talking on track, off track, and shoulder instability. And he was one of those genuinely kind men to move that. We have a great picture of me and Cassandra Lee holding our arms in that sort of gunslinger stance, like he had that one article he wrote. But it was just kind of, I think it's been so cool just to watch the contributors to this whole understanding of shoulder instability and seeing kind of the different, like you said, the science we've learned the past 5 to 10 years. And what we've been able to apply to our practice translational research. How about you, John? Where do you see us going with all this?
Yeah, no, I agree. I think we're at a stage today, more than any other time, where you can describe the remplissage as like Frank's hot sauce. I don't know if you guys like Frank's hot sauce, but the slogan is I put that on everything. It might be missing a word or two in there. But it's pretty. It seems like that's where we're at today. So I agree 100% with that. I mean, I think we're seeing. I was just thinking as Brian was talking there, the percentage of folks percentage of football players that I see. I think my football players, I'd say it's 50-50 anterior versus posterior. I think that's changed for me. I think it used to be more anterior, certainly with combined pathology, but gosh, I think it might be 50-50 with just posteriors that at least I'm seeing these days. But yeah, I think those two things are the biggest thing, and obviously the evolution of kind of the bone blocks and glenoid reconstructions.
My last podcast was with Volker Wissal and Al Getgood about ACL, precision ACL, and I feel like the remplissage and LAT kind of go hand in hand as far as implementation, and you see you're kind of starting to use it for everything. It's kind of, in the revision setting in particular, you almost wonder when not to use the LAT, and the remplissage, I think, is one of those things where I think when we were using it, we're like, we're going to cause loss of motion. They're not going to move their arm the way they're moving that. I don't think we're seeing that, and I think it's a pretty nice adjunct to that anterior stabilization procedure to make sure you don't have a Hill Sachs that's going to engage after your soft tissue procedure in the foot. So,
and Winston, I think too, I agree 100%. I think it is the engagement in the abduction external rotation position, but it's almost like a secondary check rein that suspends that shoulder posteriorly. You know what I mean? And it's an interesting concept. Some people have talked about, like Brian was mentioning, for an anterior instability, putting a posterior anchor in, and it's sort of, it's not. it brings up that posterior sling. That also might have a little bit of the same effect too, as just a little bit of a posterior suspension. So it's holding that humerus posteriorly as well. So it's some interesting concepts, but yeah.
I think a lot of it is trying to reduce that shorter capsular volume, that volume of the joint. And, someone who's had anterior instability event, at one point that ball was completely out of the socket and everything inside that joint's been stretched out. It's one of those things where I don't even think that we put things back in the right spot. There's still, the capsule is still something I don't completely understand. And so I do think that we're still, developing understanding and looking through your author list. We've got some of the brightest minds as far as shoulder instability across this entire issue. And so I think that this issue, going through it from chapter 1 to chapter 14, is basically everything you could possibly need to understand and help treat your athletes who have shoulder instability. So thank you, Brian. Thank you, John. This is really an outstanding addition to the Clinics in Sports Medicine series. I think that these are one of these issues that I think is required reading for anybody taking care of any athlete, especially football players. So thank you so much for your time tonight, and for putting in this outstanding issue.
Thanks, Winston. It's a ton of fun, and love getting to work with you all and the authors. So I really appreciate it.
Thanks, Winston. Really appreciate you giving us the opportunity to do this.
Looks very good. So thank you guys for this podcast, and we'll see you guys next time.
Thank you for joining us for this edition of the Clinics in Sports Medicine podcast series. For an exclusive discount on the issue we discussed today, focusing on shoulder instability, visit us.elsevierhealth.com/expert. Clinics in Sports Medicine is available for individual print subscription with accompanying online access, or individual online-only access, and is also available on the Elsevier electronic platforms, Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Clinics in Sports Medicine podcast. Till next time.